Welcome to the Radonc Smart Review Head and Neck Cancer series.
It's great to be back.
We are diving into episode 27b, Early Larynx Planning Workshop.
Yep.
Now, if you tuned in for episode 27, you'll remember we covered the what. We established that early glottic cancer is highly radiocurable. It's one of our biggest success stories.
For sure.
We also talked about how 2.25 gray per fraction is our workhorse fractionation schedule,
Right.
just to get that biological effective dose high enough.
Right, and then we generally leave the neck alone. The nodal risk is, what, less than 5%, so it's not indicated.
Exactly. That was the foundational knowledge, the textbook stuff,
Was. But today, we are shifting gears entirely. Today is all about the how. We are taking that theoretical knowledge, and we're walking over to the planning station. Our mission here is to build a plan that, you can not only defend confidently on your oral boards.
When the examiner is staring you down.
Oh, absolutely. But, and this is more important, a plan that you can deliver safely and effectively in the clinic to a real human being.
And I think it is important to start with a bit of a reality check, because on paper, T1 glottic cancer sounds easy. It's a small field, no nodes, simple setup.
Seems simple.
But when we look at early glottic failures, they're absolutely heartbreaking because, in retrospect, they're usually preventable.
They really are. It's the tragedy of the quote-unquote easy case. You let your guard down.
Yeah.
And here's the thing that every resident, every junior attending needs to internalize.
What's that?
When these cases fail, it is rarely because you picked the wrong dose.
Yeah.
It's not because you chose 63 gray instead of 65 gray. That small dose difference, that's not the driver.
No.
Failures happen because of geometry fit.
It's a geometric miss.
Precisely. Failures happen because the setup drifted over the course of treatment and maybe nobody caught it. They happen because the anterior commissure, the AC, was cold. They happen because the anterior flash was inadequate, so you lost electronic equilibrium right at the skin surface.
Yeah.
Or, and this is probably the biggest trap of modern planning,
I think I know where you're going with this.
it's because someone chased homogeneity on a color wash. They wanted the plan to look smooth and uniform, and in doing so, they created the exact undercoverage that causes a recurrence.
That is such a crucial distinction. We are prioritizing oncologic coverage over a pretty picture. It's just raw physics, not aesthetics.
Exactly.
So by the end of this workshop, our goal is for you to be able to simulate a patient correctly, build a classic opposed-lateral plan from scratch, explain those really nuanced trade-offs between wedges and bolus.
And articulate clearly when IMRT is reasonable and, crucially, what's proven versus what's still unproven in that space.
Let's get to work.
All right, let's do it.
Let's bring back our patient from episode 27. We have a 58-year-old man. He presents with a T1A N0 glottic squamous cell carcinoma. The tumor is on the middle third of his right true vocal cord.
And let's just visualize the key negatives here, because the negatives, they really define the plan as much as the positives.
Okay.
So no anterior commissure involvement. That's huge. Normal vocal cord mobility, so the muscle isn't deeply invaded. No subglottic extension, and no clinically apparent nodes.
Exactly. So he's been worked up, staging is complete, and now he is in your CT simulation suite, ready for planning. Your job is to deliver a plan that is, well, oncologically sound, functionally protective, forgiving of real-world motion, and reproducible day after day for 28 fractions.
Before we even touch a button on the machine or the planning software, I want to anchor us with 4 board pearls. These are the planning principles that should guide every single decision you make for a larynx case.
Okay.
If you get lost in the weeds, you come back to these pearls.
Let's hear them. What's pearl 1?
Pearl 1. The anterior commissure is a coverage problem, not a homogeneity problem.
Say more about that.
I cannot stress this enough. The AC sits just millimeters from the skin surface. It is notoriously difficult to dose properly. So if you try to fix an anterior hotspot by throwing in a big wedge,
Which is so tempting to do.
it's so tempting. But you're essentially pulling the dose back from that anterior edge, and in doing so, you create a cold spot right at the AC. You've just prioritized a pretty dose cloud over a cure. You've done harm.
That is such a common trap. You look at the slice, you see that bright red 110% hot spot at the front of the neck, and your gut instinct is just fix it.
Right.
But you forget that the tumor, or at least the highest risk area, is sitting right inside that red zone. Okay, pearl 2.
Pearl 2 is all about geometry. Opposed-laterals remain the standard because they are inherently motion-forgiving. We have to remember the anatomy here. The larynx is not some static block of cement bolted to the table. It is a dynamic organ. It moves when you swallow. It moves when you breathe. That geometric forgiveness of an opposed lateral field, where you're flashing basically the whole anterior neck, that's a feature, not a lack of sophistication.
I love that phrasing. It's a feature, not a bug.
Yeah.
We aren't doing 3D because we don't know how to do IMRT.
No.
We're doing it because it handles the chaotic motion of a swallow much better than a tight gradient can.
Exactly.
Pearl 3.
Pearl 3 addresses field size. Small fields are acceptable.
Okay.
And we have evidence for this. Chitani's randomized data, which is a classic paper, everyone should know it, showed similar control rates with less toxicity using 5 by 5 centimeter fields versus 6 by 6 centimeter fields.
So we don't need to treat the whole neck just to feel safe. We can be precise. There's often this fear that 5 by 5 is too tight, that we're going to miss.
But the data just doesn't support that fear.
No.
And finally, Pearl 4.
Let's have it.
Pearl 4 is about being honest when it comes to IMRT.
Oh.
If you were going to use IMRT, you must be honest about what is proven versus what is unproven.
Okay.
What is proven? Carotid dose reduction. The physics supports that, no question. What is unproven? Whether that actually translates to stroke reduction in the real world, or if it provides oncologic equivalence in a broad practice setting where daily setup might not be perfect.
Excellent. Okay, let's move into the room. We are at the simulator. Simulation setup. This seems basic, but if you get this wrong, everything downstream is a struggle.
Oh, absolutely. You cannot plan your way out of a bad sim.
Oh.
A clean, reproducible simulation makes your life easier for the next 6 weeks. If the patient is uncomfortable or unstable, every single daily image is going to be a fight.
So let's talk positioning. How are we placing this patient on the table?
We want the patient supine. The head should be neutral to just slight extension. The goal here is twofold. Have a stable larynx and get the mandible comfortably out of the way without forcing the patient into some awkward strained posture. You want to open up that neck angle just enough to clear the jaw, but not so much that they're straining to hold it.
And what is the most common error you see here?
Inconsistent neck flexion and extension. It's a subtle thing.
Right.
But if the chin position varies day to day, your relationship between the vocal cords and the spine changes, and all your landmarks drift.
So if they're tucked one day and extended the next.
Your CTV is moving relative to the vertebral bodies, which we often use for daily alignment. It throws everything off.
Immobilization. Are we just taping the head down and hoping for the best here?
Definitely not. No, we want a 5-point thermoplastic mask.
Yeah.
Head and shoulders.
The shoulders are critical.
They're absolutely critical. They have to be reproducible. If the shoulders drift up during treatment, which happens all the time when patients get tense, your posterior borders and your depth geometry change completely.
Oh.
The beam has to pass through more shoulder tissue, and that changes the dosimetry.
What about shoulder pulls? I know some centers swear by them, others don't like them.
You can use shoulder pulls or some gentle taping if you need to, but you have to prioritize comfort. If the patient is fighting the pulls, if they're straining against the straps, they won't be reproducible.
Right, they'll just fatigue.
They'll fatigue halfway through the fraction, and their shoulders will creep right up. A relaxed patient in a mask is always better than a tortured patient in straps.
Okay, now for the CT technique itself, what are our scan parameters? This is where the details really matter.
Slice thickness is paramount. It must be less than or equal to 2 millimeters. This comes straight from the Dahanka guidelines. You need that fine resolution to see the laryngeal anatomy.
Right.
Remember, in these early glottic cases, you are not contouring some bulky, obvious GPV.
Yeah.
You're planning around small mucosal disease and critical functional structures like the arytenoids. You need that granular detail.
So you can distinguish the true vocal cord from the false cord.
Exactly.
What about contrast? Do we need to push IV dye for this?
It's not routinely required for a T1N0 case. The air tissue interface in the larynx provides a really nice natural contrast so you can see the airway clearly.
But are there times you would use it?
Oh, sure. It can be useful if the anatomy is a bit unclear on the non-con scan, or if you're really trying to delineate the vascular anatomy for, say, carotid sparing later on.
And MRI. Is that routine for a classic T1A? We love MRI in head and neck, but is it really necessary here?
No, not for a classic T1A with clearly localized disease. But you should absolutely add an MRI if there is uncertainty.
For instance.
If you aren't sure about the subsite extent, if you're worried about cartilage involvement, which changes the T stage entirely, or if there's possible paraglottic space invasion. Also, if your endoscopic description from the surgeon doesn't quite match what you see on CT, get the MRI to be the tiebreaker.
Okay, but what if the tumor isn't visible on diagnostic imaging? This always freaks residents out. They want to see the tumor to contour it.
And that's a fair concern, but Dahanka is explicit on this. If the tumor isn't visible on diagnostic imaging, which is typical for some T1N0 glottic cases because it's just a mucosal irregularity, TNR is not indicated.
So don't go hunting for ghosts.
Exactly. Don't go hunting for ghosts. Trust your endoscopy report and your anatomical landmarks. You treat the anatomy of the vocal cord, not just a blob on a screen.
Okay, so we have our scan. The patient has gone home. Let's sit down at the planning station with our dosimetrist. We're going to build a 2D opposed-lateral technique. This is the core skill every radiation oncologist has to own.
Absolutely. It is the foundation. Even if you love IMRT, you need to know how to do this cold.
What's the goal here?
The goal is to cover the glottic larynx, and that includes the true chords, the false chords, the anterior commissure, and the immediate subglottis, with a simple geometry that you can reproduce every single day.
Okay, let's walk through the field borders using DRR landmarks. This is classic board exam material. For a T1 glottic cancer, where is our superior border?
Superior border is at the thyroid notch. This generally covers the false chords and gives you a good margin above the true chords.
And inferior.
The bottom of the cricoid cartilage. This makes sure we're covering the subglottic region sufficiently for a T1 lesion.
Okay, anterior border. This is the one people always mess up.
You need flash. Specifically, 1 centimeter of flash beyond the skin. And this isn't just about covering the skin.
Yo, it's about the physics.
It's about ensuring electronic equilibrium. And practically, it accounts for the fact that the patient breathes. If the chest rises or the neck swells, you don't want the skin falling out of the field. This ensures that the anterior skin surface and the AC, right underneath it, receives full dose.
And posterior.
The anterior aspect of the vertebral body. It's a great bony landmark, easy to see on a portal image. It generally gives you enough margin posteriorly to cover the arytenoids while sparing the spinal cord.
Now, what if we have a T2 or there's some extension? How do those borders change? We need to be adaptive.
Good question. If there is supraglottic extension, you move the superior border up, typically about 1 centimeter above the thyroid notch, up towards the hyoid bone. You have to chase the anatomy.
And for subglottic extension?
You drop the inferior border to 1 tracheal ring below the cricoid to get a safe margin.
Does the posterior border change for those cases?
It usually stays at the anterior vertebral body, or sometimes we might split the vertebral body depending on the anatomy. The principle is just to clear the disease with margin. You might need to go a bit more posterior if the disease is wrapping around, but you have to keep a close eye on the spinal cord dose.
Let's talk field size. You mentioned Chitani earlier. Let's dig into that logic.
Yes. So the historical standard was often a 6x6 field. It just felt safe, it was big. But Chitani, way back in 1996, he challenged that.
And what did he find?
He showed that a 5x5 equivalent is just as effective for control. But the real win was toxicity. The smaller field resulted in less acute mucosal toxicity, so less misery for the patient during treatment, and less persistent arytenoid edema, which means better long-term voice quality.
So the teaching point is, don't just default to 6x6 because that's what you saw someone do as a medical student.
Exactly. Size the field to the anatomy, not to have it. If you have a petite female patient with a short neck, a 6x6 field is going to be irradiating her mandible and her clavicles. That's just bad medicine.
Defend your field size with coverage logic, not tradition.
That's it.
Let's set our isocenter. Where does that go?
At the level of the true vocal cord. This is usually around the C5 or C6 vertebral body. You want the center of the beam passing right through the target.
And energy. This is a physics hard stop.
6 MV photons. Do not use higher energy. Do not use 10 MV or 15 MV.
Why not?
Well, higher energy beams have a deeper Dmax, the depth of maximum dose. For 15 MV, Dmax is roughly 3 centimeters deep. That means the first few centimeters of tissue are in the buildup region, and they are underdosed.
And the anterior commissure sits
Less than 1 centimeter from the skin. So if you use high energy, you are effectively sparing the tumor.
That's a critical concept. High energy spares skin, but in this case, the skin zone contains the cancer. What about weighting?
Start symmetric. 50-50. Only adjust the weighting if you're trying to solve a specific articulable problem, but always start neutral.
Okay, now we get to the part where I feel like residents, and honestly some attendings, get into real trouble. Wedges and bolus. It's the battle of the isodose lines.
This is absolutely where people make the plan look prettier on the screen, but perform worse in the patient. It's the Photoshop phase of planning, and it can be really dangerous.
So let's unpack the core principle here. Why do we even reach for a wedge? What is the geometry doing to our dose?
Well, think about the shape of the neck. It's kind of cylindrical, but it's much thinner anteriorly at the Adam's apple than it is posteriorly at the shoulders.
Right.
So when you shoot those opposed-lateral beams, they overlap. And because the tissue is thin anteriorly, there is less attenuation. So you naturally create a hot spot right up front.
So logically, a wedge, which is just a piece of metal, physically or virtually, that's thicker at one end, can compensate. If you put the thick part, the heel, anteriorly, it attenuates that beam and it cools the hot spot.
Correct. That is the theory. But here's the price you pay. A wedge reduces the anterior dose. It pushes the isodose lines deeper into the neck.
Yeah.
And where's the anterior commissure?
It's anterior.
It is anterior.
Yeah.
That's exactly where you cannot afford to be cold.
So if you're staring at your dose cloud and you see that hot spot, you might be tempted to just throw in a 45 or even a 60-degree wedge to smooth it all out. You want to turn that red cloud into a nice uniform green cloud.
And that is the trap. You are solving a homogeneity problem, making the colors look uniform, but you are creating a coverage problem. The AC drops below the 95% isodose line. You've essentially carved the dose out of the tumor to save the skin.
So what is the practical workflow to avoid this? How do we thread this needle?
Okay, step 1. Build the open field plan, no wedges at all, and evaluate your coverage. You will see a hot spot anteriorly. That's expected. Just accept it for a moment.
Step 2.
Step 2. Add a modest wedge. I'm talking 15 to 30 degrees, heels anterior. Only do this as needed. Don't just start with 60 degrees.
Right.
Step 3. Recheck the anterior commissure on the isodose display explicitly. Zoom way in. Look at the 95% line relative to the thyroid cartilage.
And step 4, if you see a problem.
If the AC is cold, meaning it's getting less than 95% of the prescription, you have a problem. You must reduce the wedge. That's your first move.
What about bolus? Is that a routine thing?
Bolus is not routine, but it's a very elegant fix for specific situations.
Like when?
You use it when there's definite AC involvement or proximity to it. Or if your wedge strategy, even after you've reduced the wedge, still leaves a persistent anterior cold region because the patient has a very sharp, thin neck.
Or if you just need superficial buildup for skin involvement.
Right. So the decision sequence is this. If your AC coverage is borderline, your first move is always to reduce the wedge. If reducing the wedge brings back an unacceptable hotspot.
So you can't get coverage without burning the skin.
Right. Creating wet desquamation right over the cartilage. Then, and only then, you add a thin anterior bolus, usually 5 millimeters, to restore that coverage and build up.
And just to hammer this home, what is the mandatory check? What's the pass-fail metric for any of these plans?
Your 95% isodose line must include the true vocal cords, the false cords region, and the anterior commissure. The AC is the failure mode. If the 95% line cuts across the AC, you change the plan, period. You do not treat that plan.
Okay, let's talk about motion. We touched on it in the pearls, but let's really look at the data. Why is motion such a huge deal in the larynx?
Because the larynx is part of the swallowing mechanism. I mean, it is designed to move. CineMRI studies have actually quantified this. When a patient swallows, the mean superior movement is approximately 23 millimeters.
23 millimeters. That's over 2 centimeters.
It's a huge jump. And the anterior movement is about 6 millimeters.
What about just regular respiratory motion?
That's much smaller, on the order of just a few millimeters. But that swallow, that's a massive excursion. It's like a jump scare in a horror movie. It's sudden, and it's significant.
And we know mid-treatment swallows happen.
Oh yeah, not every patient swallows during BMON time, but you cannot plan assuming no motion. That is a complete fallacy. If you contour your PTV with tight margins and assume the larynx stays put, you're just wrong.
This brings us right back to why opposed laterals win here. It's that flashlight concept, right?
It's all about the beam's eye view. Imagine shining a flashlight on the neck from the side. With a classic opposed lateral field, the entire larynx is inside that open field.
So even if it moves,
Even if the larynx jumps up 2 centimeters, it's likely still within the superior border of your field, or at least mostly within it. The target stays inside the treated volume, because the treated volume is just a big, open box.
now contrast that with IMRT.
Well, IMRT cards dose tight to the target. It relies on these steep gradients. It tries to paint the dose right to the edge of the vocal cord to spare the carotid. If you use those tight IMRT gradients, you are effectively betting that your margins, your motion management, and your daily verification are good enough to compensate for that 23 mm jump.
That's a very risky bet if you aren't fully prepared for it. If the larynx jumps up and your high-dose volume doesn't jump with it, you are treating air and missing the cancer.
It might be appropriate in some select patients, but it is not automatically better just because the technology is newer. Newer isn't always better. Sometimes it's just more complex and more risky.
So let's break down that decision-making. 3D conformal versus IMRT.
For most early glottic cases, 3D conformal, which is basically just a modern opposed-lateral technique with better calculation, remains the standard of care. It's simple, it's robust, and it's reproducible.
But IMRT is so seductive, it promises organ sparing. Everyone wants to spare the carotids.
It does, but you have to frame the trade-off correctly. If you were even considering IMRT for this, you have to say this yourself. I am trading motion forgiveness for carotid sparing. You are giving up geometric safety to gain dosimetric sparing.
That is the trade.
That's the trade. Now let's look at what is proven versus what's unproven. Proven. IMRT reduces carotid dose compared to opposed laterals. We know this. The dosimetry is clear. Unproven. That this dosimetric reduction actually translates to fewer strokes in this specific population. We assume it does, but the direct clinical link is less robust.
Okay.
And also unproven is that broad, real-world implementation of IMRT maintains the same excellent local control as opposed laterals, given that motion we just talked about.
Right, the risk of a geographic miss.
Exactly.
So when should we escalate to IMRT? When is it the right choice? Because we do use it sometimes.
There are clear indications. One, significant supraglottic or subglottic extension where you actually need nodal coverage. You're treating nodes, you need IMRT to spare the parotids and cord.
Okay.
2, a T case with planned concurrent chemotherapy. 3, a reirradiation setting where you need extreme conformality. 4, a patient with prior neck RT where the cumulative carotid dose is a real immediate concern.
What about vascular risk?
That's number 5. A patient with a specific high-risk vascular profile, like a prior stroke or severe carotid stenosis, where every single grade of that vessel really matters.
But for our straightforward T1 patient?
Opposed laterals remain the standard. Keep it simple. Keep it safe.
Okay, but let's say we have decided to use IMRT for a good reason. Maybe this patient has severe carotid stenosis. If we are going to do it, we absolutely have to do it right.
And this is a huge pet peeve of mine. So many of the published carotid sparing series didn't actually use explicit carotid constraints. If you don't constrain the organ, you aren't sparing it. You're just getting lucky with the anatomy.
So let's walk through the standardized approach per Goudral et al. This is the paper, to quote, on boards. How do we contour?
You contour the left and right carotids separately. Do not combine them into one structure. The dose is likely asymmetric. You need to evaluate them independently. Then you add a carotid PRVA planning organ at risk volume. This should be 4 to 6 millimeters.
4 to 6 millimeters? That seems like a lot for a vessel. Why so much?
It accounts for the approximately 1 millimeter systolic diameter change, the actual pulsing of the artery, plus your daily set of variation. The vessel moves, it expands, it contracts.
And the constraints.
You want to aim for a carotid max of less than 35 gray. And you aim for a mean carotid PRV of less than 20 grays, if that's feasible.
What about the target volumes? The CTV and PTV?
This is critical. You have to treat a generous larynx CTV. Do not be microconformal. Don't just contour the GTV plus 5 millimeters, and you must use motion-aware margins.
So don't assume 3 to 5 millimeters is automatically safe just because it's head and neck.
No. The larynx is mobile. You have to respect that. And per consensus guidelines, the total CTV should measure greater than or equal to 2 centimeters craniocaudally to account for that swallow.
And the spinal cord?
You contour it from the foramen magnum down to at least 2.5 centimeters below the PTV. And you add a 3 to 5 millimeter PRV and document the PRV max.
I love that reality check. If you aren't contouring carotids and PRVs with explicit constraints, you are not doing carotid-sparing IMRT.
You're just using IMRT and hoping. And hope is not a plan.
Okay, plan's done. We're sitting down to review it. Give us the plan evaluation checklist. I want our listeners to have this just printed in their brains.
Okay, do this the same way every time. Be systematic. For opposed laterals. 1. Coverage. Does the 95% isodose line encompass the TVC, the FVC, and the anterior commissure?
Yeah.
Zoom in on the AC.
Number 2.
2. The AC check. Explicitly look for a cold spot after you've put the wedge in. Don't just glance. Actively hunt for it. Assume it's there until you prove it's not.
Okay.
3. Heterogeneity. Are the anterior hotspot acceptable? 110 to 115% is fine. It's expected. An AC cold spot is not acceptable. 4, make sure you're not unnecessarily dosing the posterior pharynx. 5, check that the spinal cord is well below tolerance. And 6, flash. Is anterior flash present and reproducible? Is it really 1 centimeter?
And if we are using IMRT, what do we add to that list?
You add item 7, carotids, left and right. Document the max and mean to both the OAR and the PRV. Confirm they are below constraints. Item 8, cord PRV. Document the max dose. And item 9, maybe the most important, motion robustness. Ask yourself, would this plan still cover the target if the larynx moves 20 millimeters superiorly?
That is a scary question if your margins are tight.
It's the most important question. It's the question that saves you from a recurrence.
Let's shift to the patient experience. Counseling and follow-up. The plan is great, but now the patient has to live through it. What do we tell them about the timeline?
We break it down into phases. Weeks 1 to 6 during treatment. You tell them to expect progressive hoarseness, throat discomfort, and some mild dysphagia. This usually peaks around week 4 or 5. The voice will get worse before it gets better.
Supportive care is key there.
Oh, absolutely. Hydration, soft diet, voice rest when possible. Tell them not to strain their voice.
Then the recovery phase. This is where patients get anxious, right? The radiation stops, but the side effects are still there.
Yes. Week 6 to 12. There's a gradual voice improvement over 2 to 3 months. But you have to tell them. Some residual hoarseness initially is common and expected. Don't panic if the voice isn't perfect the week after treatment ends. That edema takes time to resolve.
And long-term?
Most patients achieve a good to excellent voice quality. Mild chronic hoarseness is pretty common. Laryngeal edema can persist, but stenosis is rare. We're talking less than 5%. And compared to surgery, radiation produces a less breathy voice. They get to keep their native organ.
How do we follow them?
The first NPL nasopharyngeal endoscopy should be about 6 to 8 weeks post-treatment. This lets the acute changes settle, so you're not just looking at raw inflammation. Then every 3 months for 2 years, and then every 6 months after that.
And what if there's a recurrence? What's the salvage expectation we should set?
Salvage laryngectomy can achieve greater than 90% ultimate local control. However, and this is a sobering statistic, only about 50 to 70% of recurrences are successfully salvaged. It means if we miss the first time, we might lose the chance for cure in a significant chunk of patients.
Right.
And of course, wound healing is much more challenging after RT.
So the line I like to use with patients is something like, we plan this very carefully because the first horse gives you the best chance of cure with the best voice.
That is the perfect summary. It sets the stakes exactly right.
Before we hit the board blitz, let's summarize the 3 common mistakes. These are the things that fail boards and, more importantly, fail patients.
Okay, mistake 1, over-wedging. Creating an AC cold spot to fix a hot spot. It is the #1 failure mode. Always verify 95% coverage at the AC. If you take nothing else from this episode, take that.
Mistake 2.
Mistake 2, using IMRT without accounting for motion. The larynx moves. If you use tight gradients without robust margins and verification, you are setting yourself up for a geographic miss.
And mistake 3.
Mistake 3, missing flash. The anterior commissure sits just deep to the skin. If you don't have adequate flash, you risk a marginal miss at the most common failure site. Simple as that.
All right, let's test this knowledge. It's time for the board blitz. I'll pose the scenario, you give me the answer and the rationale. Imagine you're in the hot seat.
I'm ready. Let's do it.
Question 1. During planning for T1A N0 glottic cancer with opposed-lateral fields, you notice the 95% isodose line does not fully cover the anterior commissure. What is the most appropriate next step? A. Accept scatter provides adequate dose. B. Increase wedge angle to improve homogeneity. C. Reduce wedge angle or add thin anterior bolus. Or D. Convert to IMRT for better conformality.
The best answer is C. Reduce the wedge angle or add a thin anterior bolus.
Why?
Because this is a classic AC coverage problem. Reducing the wedge angle increases the anterior dose by removing some attenuation. Adding bolus builds up the dose superficially. Either one of those 2 actions fixes the cold spot.
And what's the trap here?
The trap is B. Increasing the wedge angle makes the cold spot even worse. That's probably how you created the problem in the first place. And D, converting to IMRT, is not standard for early glottic, and it introduces motion uncertainty without solving the fundamental physics issue. You're jumping to a complex solution for a simple physics problem.
Perfect. Question 2. You are planning carotid-sparing IMRT for a patient with T1b, N0 glottic cancer, and a prior TIA. Which approach is most appropriate? A. Contour a combined bilateral carotid structure and aim for mean less than 40 grays. B. Contour left and right carotids separately with 4 to 6 millimeter PRV. Aim for max less than 35 gray and mean PRV less than 20 grays. C. Use standard 3 millimeter PTV margin since IGRT compensates for motion. Or D. Omit carotid constraints since the dose is inherently low with small field RT.
The best answer there is B.
Walk us through it.
Well, standardized carotid sparing per Gujral et al. Requires separate left and right carotid OARS.
Yeah.
You need that PRV of 4 to 6 millimeters to account for pulsation and setup, and you need those explicit constraints. Max less than 35 gray and mean PRV less than 20 gray.
And why are the others wrong?
Option A uses the wrong structure. A combined structure means you might overdose one side while sparing the other, and the wrong constraint. Option C ignores that huge laryngeal motion we talked about. 3 millimeters is not automatically safe just because you're using imaging. And option D misses the entire point of doing carotid sparing IMRT. If you aren't constraining it, you can't call it sparing.
Excellent review. That really covers the scenarios.
Yeah, I think looking forward, the key takeaway from today is that opposed laterals remain standard for early glottic cancer because they're reproducible and they are forgiving of laryngeal motion.
And small fields are okay.
Small fields are acceptable when coverage is correct. Wedges solve hot spots but can create cold spots, and the AC is where you absolutely cannot afford to be cold.
And if you choose IMRT,
You have to be explicit about what's proven versus unproven, and you have to do it right with proper OARs, PRVs, and constraints. Don't dabble in IMRT. You have to commit to doing it correctly.
next episode, episode 28, we are tackling organ preservation, the landmark trials. We'll move from early glottic to locally advanced larynx and dissect the trials that establish chemoradiation as an alternative to laryngectomy. VA Larynx, RTOG 9111, and Gore-Tex 2001.
That is going to be a heavy-hitting episode. We're going to look at the data that really defined a generation of organ preservation.
Let's recap the essentials from this planning workshop one last time.
Opposed laterals work because they forgive motion. Swallowing excursions can exceed 2 centimeters. Classic fields handle this. Tight IMRT gradients might not. Small fields 5x5 are safe and reduce toxicity. Wedges are tools. Don't let them create an AZ cold spot. And if you do carotid sparing, contour separately, add a PRV, and set explicit constraints.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.